So my name is Barry Trachtenberg. I'm in Houston at Houston Methodist Hospital. I wanted to present some cases of advanced heart failure with cardiology. So we'll get started. The first case is an 83-year-old pediatrician who has a history of stage 3 diffuse large B-cell lymphoma that was diagnosed earlier this year. Underwent 8 cycles of R-CHOP with a total adriamycin dose of 400 milligrams per meter squared. This last cycle was 5 months before he presented with weakness, shortness of breath, and pain in his jaw. He has had these symptoms for approximately 2 weeks. Pertinent past medical history is paroxysmal atrial fibrillation, a syncope and with a bivesicular block, and he had a dual pacemaker 2 years prior, and no tobacco or alcohol. His exam, his blood pressure was 101/60, heart rate 95, respiration was 18. Pertinence on the exam, he has a 2 out of 6 systolic murmur at the apex. Jugular venous pressure was approximately 10 centimeters of water. He had an S3 gallop, decreased breath sounds at the bases. Otherwise, the exam was largely unremarkable. His lab findings to the right, he had a troponin of 0.3, ENP of 3,000, and chemistry on the right. Please interrupt if there's any questions at all. Here's his EKG when he presents. So it looks like he's in sinus rhythm. He has a bivesicular block, and he has a first-degree AV block as well. Incidentally, this is an echo that he had 3 months before this admission, and unfortunately it wasn't really picked up or paid attention to by the treating physician. This is his strain imaging, and even though his EF, you can see here, was 50 to 54%, his global longitudinal strain was abnormal, was negative 15.9, and you can see on the bullseye view here that where you should see relatively uniform color, there are areas of regional differences in strain. His average GLPS should be less than negative 18, and it's negative 15.9. So he probably had a sign that was missed a few months prior to this admission. His echo 4 months prior to this abnormal one, so about 7 months before he presented, showed that he had a preserved ejection fraction, and unfortunately strain wasn't performed in that. It was just recently implemented as part of the protocol here.
Say, Barry, is that strain indicative of coronary artery disease in terms of renal dysfunction, or does it mean that the patient was pacing at the time the strain was calculated and at the time the echo was done, giving us a lag in strain in certain areas?
Yeah, no, that's a great question. So it could be indicative of, as you mentioned, coronary artery disease, and in his particular case, we'll see that it wasn't. So it could be regional pacing, absolutely. I don't know if he was pacing at the time of the echo, but nevertheless, he did have certainly a signal there of abnormality, and I don't believe he was pacer dependent.
It looks like the heart rate was 65, and usually the pacers are set at like 72 or something.
Yeah, his pacer.
He may have been pacing then, because when it drops below 70, usually people start pacing.
Yeah, I don't know what his setting was. It's a great point. It very well could be, and it's a great point to remember about strain and certainly the limitations and caveats that you have to take into account with strain. So to be honest, I don't know if he was pacing at that point. That's a great point. But nevertheless, his EF was a little bit lower than his baseline, even though there was a range of abnormalities, certainly by the eyeball test. So certainly there was a signal there, perhaps, that was not worked on.
So even if he wasn't pacing, he does have a significant conduction delay on his cardiogram. So He doesn't make that much.
So moving on to his echo from this emission, so you can see there's a marked variation. His EF is now dropped to 30 to 34%. There's some RV dysfunction. He has grade 2 diastolic dysfunction, elevated PA pressures, and evidence of volume overload. And he was admitted for new onset heart failure. He was diuresed. He had a coronary angiogram that was negative. He was initiated on a low-dose blood pressure limited heart failure regimen and was discharged after a few days. So in the meantime, he went across the street to MD Anderson for a second opinion regarding his lymphoma, where he was previously treated here. And he had recurrent pleural effusions, which were drains, and they placed a pleural drain. The fluid came back as transitive, and it was negative for malignancy. He was now transferred back to our institution for further management of his heart failure, and at that time he reports a strong feeling of shortness of breath. He's currently on 15 liters of a non-rebreather mask, denies any chest pain or palpitations, and his CT chest showed pulmonary edema, left pleural effusion, and persistent moderate right pleural effusion despite the pleural drain. And here are his labs. Are you guys able to see those labs? Are they not showing up? So his BNP is 4,000. His sodium is in the 120s, little 120s. His creatinine is now 1.6, whereas his baseline was 1.1. So any thoughts at this point? No, let me show you his echo, then we can go into further discussion. This is a repeat echo when he came back. Is this playing on your screen?
I don't see anything on the screen yet. It says playing video, but I don't see anything.
Yeah, I'm not sure. I have it on two screens. One screen is in there, it's not. Let's see if yes, sorry this isn't playing, but you can see in the first view is a parasternal long view. You can see a significant LVF, EF depression, a large left pleural effusion. The second view just shows you it's a four-chamber view, and RV is also quite enlarged as well. The readings from his echo, sorry that's not playing, showed severe LV enlargement, LVF 20-24%, RV function is down. He's got moderate to severe MR. And if you look at, he underwent a right heart catheterization, and his right atrial pressure was 18 relative to a wedge pressure of 28. Pulmonary artery pressure was 50/30, mean of 37, and his cardiac output index 2.6 and 1.3 here. So any thoughts on what what you guys would do as the next step? Suggestions, comments? I'll go ahead and tell you what happened here. So despite inotropes and he was transferred to the CCU with inotropic support and Swan-Taylor therapy, and he had progressive heart failure and cardiorenal syndrome despite that. You can see his labs starting from right to left. At this point, an intra-aortic balloon pump was placed because the inotropes were not enough support. His lactic acid, after the balloon pump was placed, went from 3.6 to 1.4. You can see within 24 hours his creatinine started to improve. And so we have an 83-year-old in the CCU on a balloon pump support and inotropes with a diagnosis of DLBCL. In discussions with his oncologist, he was given a 40% chance of long-term remission. And at that point, after several days of being in the CCU, bedridden with the balloon pump, we switched the balloon pump to the axillary position so he can ambulate and not get bed sores. And just as a little background about this is an axillary balloon pump is something that we've done quite a bit of here using, without surgery involvement, really just doing a percutaneous puncture at the axillary artery. And we've used this successfully previously as a bridge to transplant strategy in patients awaiting transplant, and have had quite a bit of success with this. We had 50 patients in our initial trial, and we were able to get 42 of them to transplant with axillary balloon pump and ambulation. And just briefly to discuss how we do it, we have a guide wire that's placed through the brachial artery, and we have a fluoroscopic roadmap here, and we puncture. You see the red arrow on the top picture. That's usually the puncture site, and you can see in the screen, the bottom right photo of angiography of the path we take to access the axillary artery. So using this guide wire, we puncture in 2 different views under fluoroscopy to access the artery. And this is an example of a patient that has an axillary balloon pump. They're ambulatory, you can see on the right, sitting up, eating lunch, very different than your patient that's bedridden with the balloon pump and miserable. And this is something that we've been able to do here traditionally to bridge people to transplant, but in other situations just for long-term recovery or for bridge to decisions in patients. We even had one patient waiting for transplant who walked his daughter down the aisle in our chapel with an axillary balloon pump because she was worried that he wouldn't make it to her wedding. So, and just to look at hemodynamics of patients that had axillary balloon pump support in this population, you can see even though balloon pumps have traditionally been known to have just a modest effect on cardiac output, this shows that we have had success in terms of improving hemodynamics, including decreasing right atrial pressure and mean pulmonary artery pressure, improving end organ dysfunction with creatinine and LFTs in patients on long-term balloon pump support. So this is what this gentleman had, and we were essentially in the situation with a gentleman of quite advanced age, the diagnosis of lymphoma, but he was really pushing to do everything we can, and he was of sound mind and had great family support and mental capacities, and there was a lot of deliberation about it. And initially he was accepted for an LVAD, and before it could be placed he developed C. diff and had hypotension, acute kidney injury, and was placed on hemodialysis. And because of that, we brought him back to our medical review board, and given the recent decline in kidney function and the complexity of the case, and eventually he was declined when we took him back for LVAD given his age, frailty, and malignancy, and his acute kidney injury. So it ended up after 2 or 3 days of dialysis, his kidneys made a remarkable recovery, and he was off dialysis. We tried to wean the axillary balloon pump, and he failed to wean pretty clear. When we put it on 1 to 3, his systolic blood pressure dropped into the 60s. So now we have a gentleman that's completely awake, alert, ambulatory on axillary balloon pump, now 8 weeks on support. He is currently declined for LVAD, obviously declined for transplant given his age and malignancy. And he's asked us why we're going to turn off the balloon pump. I mean, he's going to die, and he wants to live, and he wants to make it 9 months to his grandson's bar mitzvah, which is 9 months from now. So his kidneys are recovered, he's infection-free, and we took him back to our MRB for a 3rd time, and this time he was accepted for the destination LVAD. So any thoughts and comments on whether anyone else in their right mind would have considered this at your institutions?
Hello, Joe. Do you have any comments? Joe Carver.
It's Brian Jensen from UNC. I'm a heart failure transplant, bad guy. Considered it, sure. It's high risk, but if he otherwise is well supported and has recovered his end organ function, then we would consider it.
So we ended up putting the LVAD in, and he remained on post-op day 2. He's extubated. He's sitting up reading his newspaper. He remained on low-dose dobutamine for 2 weeks due to low flow on his LVAD and concerns for right ventricular failure. So we took him to the cath lab, did a right heart cath, and it turned out just to be really hypovolemia, and we were able to wean the dobutamine off. And he's doing quite well. His grandson's bar mitzvah is 2 weeks from now, and we're hoping he continues to do well. And I just wanted to talk a little bit about left ventricular assist devices in patients with chemotherapy cardiomyopathy and what we know about it. This is from Guillermo Oliveira and his retrospective review looking at Intermax database. Intermax is a database of patients with LVAD patients, and looking at patients with cardiotoxicity, CCMP versus just regular non-ischemics versus ischemics. And looking at just the baseline demographics, you can see that the chemotherapy patients are much more likely to be female. Compared to ischemics, they're less likely to be diabetic. They're more likely to be on inotropic support. You see 89% versus 83 and 80% with a trend towards increase. They're also more likely to be listed for destination therapy, 33% versus 14 versus 23. And this is most likely due to the fact that they have had malignancy within the last 5 years. But nevertheless, destination therapy typically portends a higher risk patient. And they also, if you look at their hemodynamics, one, their heart rate tends to be higher than patients that are non-ischemic or ischemic. Their right atrial pressure at baseline is higher, 16.5 versus 13 and 12. Their LV size is a little bit smaller, and this can be a worrisome thing in general for patients undergoing LVAD support, because if the LV size is too small, you can have suck-down events, and that can be a consideration. Their pulmonary systolic pressure is a little bit lower, which in the setting of the right atrial pressure being high may indicate a worse RV function going into the LVAD. This is also exemplified by a much higher likelihood of severe or moderate tricuspid regurgitation, 62% versus 43 and 49%. So you can see that the chemotherapy patients have a much higher incidence of right ventricular dysfunction going into an LVAD. And thus, after an LVAD, a much higher incidence of the need for an RVAD. You look at the top left corner, 19% of these patients, and granted this is a small cohort, 75 patients, ended up needing an RVAD in this cohort versus 11% of the non-ischemics and 6% of the ischemics. This is much higher than current day standards of RVAD use, which is the order of less than 5%. But if you look at the clinical outcomes, despite the need for RVAD, the clinical outcomes were fairly comparable among all the groups in terms of death or transplantation. And then turning towards adverse events in these groups, really the only thing that was significantly worse was the top left in A. You see that the chemotherapy patients had a worse freedom from bleeding, so they were more likely to bleed compared to other patients. And if you look at freedom from right heart failure in E, take into account that that's after the RVAD is accounted for. So long term, no changes, but certainly short term higher risk of RVAD. And then also the same Oliveira and colleagues also looked at the ISHLT transplant database and looked at patients with chemotherapy cardiomyopathy versus non-ischemic cardiomyopathy. This is an international database of patients undergoing transplant. And you can see despite the use of LVAD as a bridge to transplant being the same in both groups, about 19%, there was a 5.6% incidence of RVAD use compared to the non-ischemics. So it's about twice the likelihood of needing an RVAD in the groups that received chemotherapy. And it's thought to be due to the fact that the chemotherapy is affecting both sides of the ventricle compared to other types of cardiomyopathy. So I'm going to move on to case 2 unless there's any comments or questions.
What's the prognosis from his lymphoma at this point?
So the original prognosis was that he had a 40% chance of remission, and so 40% 2-year survival, but if he survived that, then he had a 40% 5-year survival, according to the oncologist. So right now he's been off chemotherapy. He has had some recent weight loss, so he's undergoing another PET CT scan and following up with oncology next week. But so far he's been off chemotherapy and doing okay. But it's certainly it's certainly a gamble to say the least in terms of not knowing his outcome from the chemotherapy.
Are there any patients that have LV recovery after being on LVAD for a while?
Yeah, certainly. I mean, there are, in terms of this population, or are you asking in general?
Oh, this population.
I'm not aware of much data with chemotherapy toxicity in terms of recovery from LVAD. If anyone else is, please jump in.
Who are the patients that recover? The ones with coronary artery disease?
Typically, the patients that recover, I mean, one, it also depends on how hard you're trying to recover them, and there's some discrepancy in terms of the programs that have shown the most recovery are the ones that are trying the hardest to get there. But generally, it's young patients that have had a shorter period of time with heart failure, and classically it's the non-ischemics, myocarditis, peripartum, particularly high risk for recovery in general, and especially with an LVAD. That hasn't been uniform across all the recovery data. Some data has shown there's no difference between ischemics and non-ischemics, but more data supports the fact that young age, shorter time with heart failure, and non-ischemics are more likely to recover. I haven't seen much data at all with, or even case reports that I'm aware of with chemotherapy patients. But maybe Brian Jensen wants to, if he has any comments.
Hey Barry, this is Dan Linehan from Vanderbilt. Thanks for your presentation. These are really challenging patients, of course, but in reference to Eric's question, there's really not that many patients, at least in the U.S., that actually can get their VAD extracted. I mean, it's a very small percentage of patients that have enough recovery to where they'll actually be able to extract the device. So, that's in an order of, it's probably less than 1%. And as Barry mentioned, it's really the two conditions that seem to be the ones most likely are myocarditis and postpartum. And you could argue that if you could have just ridden it out for a bit, that maybe they didn't need the LVAD. But, I mean, that's a very difficult question to address. So I think the whole LV recovery path is a very difficult one, and there's not that many places that actually successfully extract a device.
Yeah, that's right. In the Intermax registry, it's on the order of 1% in terms of recovery.
Hey, it's Joe. I have a comment. I mean, all of us see a lot of anthracycline-induced cardiomyopathy. The number of people who have a devastating course like this is like unusual. We should get some blood or tissue for genetic testing, because I think that there's probably a clue here. This is an unusual clinical course for this disease
So
in adults.
Yeah, thanks for bringing that up. We're actually doing a pilot study of gathering, just doing gene testing on all patients that present with endocytic cardiomyopathy. And this gentleman did give us a blood sample, and we haven't run anything that we get higher numbers.
Yeah, so we have attempted to look at some polymorphisms that may indicate a risk of anthracycline-related toxicity, and you are probably, I know, Joe, you're at least partially aware of the PREDICT study, which was 580 patients across the country, and there wasn't a high percentage of people that had true cardiac dysfunction, so the number of events was only in the order of 60, and so you don't have a huge population to look and see if there's a genetic marker that's associated with susceptibility. But we do have a couple of candidate genes, but I don't think it's going to be that strong. And it's probably other factors that are more important, such as cardiac risk factors or prior injury from something else. So in the case of I didn't see the beginning of this. I don't know the details of this particular patient, but we do have some really traumatic cases in adults of patients that really flame out after getting anthracyclines.
Yeah, so
This gentleman got 400 milligrams per meter squared and was 83 years old.
yeah, so this guy had bifascicular block and needed a pacemaker before he had cancer. And it's an observation not based on very much fact, but just thinking about it, that the people that I see who seem to do the worst and and really have bad LV dysfunction have underlying bad hearts to begin with, so they have left bubble before they start, or they have significant conduction system disease before they start, even with a preserved EF at time 0.
Yeah, so the conduction
look at our combined experience just in that population.
Yeah, I mean, I think the conduction disease is, probably an important marker of a myopathy that may not have been bad enough to cause significant LV dysfunction prior to treatment, but probably indicated underlying myopathy at some point.
Yeah, and when they get chemotherapy, they go to town.
I'm going to move on to the second case unless there's any comments or questions.
No, that's great.
And this was really good.
Thank you. So this is case 2. This is a 66-year-old man with a past medical history of hypertension who was diagnosed with IgA kappa multiple myeloma in 2007. And so he received thalidomide for 7 months and then went out thalidomide for 2 months, with both medications resulting in significant edema. And he switched to 3 cycles of cyclophosphamide, bortezomib, and dexamethasone. And then he had 4 cycles of bortezomib and dexamethasone alone. He developed a sudden onset of heart failure in 2007, with his EF waxing and waning between 20 and 35%. He initially deferred stem cell harvest until 2011, but at that point he had a relapse in association with worsening cytogenetics. He was admitted in 2013 with worsening dyspnea and worsening heart failure, and that's when we met him, as he was they asked the heart failure team to see him for management of his cardiomyopathy. His social history: he does have moderate alcohol use, about 4 drinks a night for several years, no tobacco, married, and family history is not significant for any cardiomyopathy or heart disease. We met him. These are his vital signs above. Pertinent positives on the exam. He had a jugular venous distension of approximately 14 centimeters of water. He 2 out of 6 milligrams. And he had an S3 gout and 2+ pitting edema diarrhea. At the time we met him, his creatinine was 2.4, his baseline was 1.4, calcium was 8.3, platelets were 111,000, his BNP was 3,800, troponin was 0.11, and he had a right heart cath done while on 5 mics of dobutamine and the Lasix strip, and at that point his right atrial pressure came down to 2, his wedge was 13, his cardiac index was 2.4, which is normal, but that's on high dose legal dose dobutamine. And
How did he end up on dobutamine?
his cardiologist that consulted us put him on dobutamine when he came in with heart failure, and then called us to help manage it. So it was mainly for cardiorenal syndrome, and I'm not really sure all the reasons why he chose to do it, but he just thought he was sick of heart failure. Thought it would be a quick fix for symptoms, and then asked us to get involved.
All right.
See if I can get this echo to play. Yeah, my apologies. It's I have 2 screens here, and the one screen is playing, the other one is not.
I'm playing.
So
one thing that I'll say about that, sometimes if you have a copy of the slide and you put the first slide when it comes up, somehow it causes some sort of disconnect, but then if you have a second slide with the exact same slide, it plays normally. I don't know why that is, but I've seen that a few times on this webinar.
is there anything I can do now to
Yeah, I think go out of your presentation and copy that slide and put it one right after it, and then go back into the presentation and click on one and then click to the next one, and it may work.
okay. Or I can just go to my I have this image saved. I can just try to show that if that works. Are you able to see?
Yeah.
Are you able to see this?
Yep.
Yes.
Four chamber. And then let me find his. And this is his peristernal long. You have some dropout at the apex, but just to give you an idea.
So how bad was the MR?
The MR was reported. Let me get the PowerPoint back up. It was I think it was moderate to severe. Let's see how to get the. Okay. Eric, is there to get back in the, oh, here we go, okay. All right, so yes, the MR was reported as moderate to severe, the recursion fraction of 45%. He also had moderate TR, and he had a previous angiogram a couple years prior, so he ended up going for coronary artery calcium score given his renal function, which was 0. So he was thought not to have coronary disease. He was deemed to be in partial remission from multiple myeloma. You see here on the top was in 2012. You see beta 2.3, and if you look down at his from his current SPET, you see that one had come down to 1.1. So he was certainly improved in terms of multiple myeloma. And in in terms of what's the cause of his cardiomyopathy. Does he have cardiac amyloid? Does he have coronary disease? I think we kind of answered that one. Alcohol abuse, cyclophosphamide, bortezomib, lenalidomide. Any thoughts on that's our differential? What would you guys want to do next?
Yeah, this is amyloid 100% of the time.
Any other? So you want to do biopsy, MRI?
You could do an MRI, I suppose, but I don't know if his creatinine is precluding the gadolinium, but because if you do an MRI without gadolinium, it's probably not going to add a whole lot. So yeah, I would favor. We sort of have a low threshold to do a biopsy, and I would say in somebody who's gotten treatment for myeloma for a long time, who presents with worsening heart failure and a BNP that high and a troponin that high, there's no other possibility.
Yeah, it's Joe. I agree. It's the problem with biopsy at this point is that it's probably not going to impact his therapy dramatically or his life expectancy. So if you could get away with, I would try a fat pad first and see if you can nail it without having to do anything invasive.
Yeah, so we see a lot of amyloid here, and we thought the same thing. So his creatinine got better. We did an MRI. You can see on the right is just a still shot of his delayed gadolinium enhancement, and there was no evidence of infiltration at all in the MRI, to our surprise. I don't know if the MRI is plain on the left just to show you his dysfunction, but so the MRI was negative for amyloid. His most recent bone marrow biopsy didn't show any evidence of amyloid, and we actually did not pursue a biopsy. And I don't remember all the details of why we didn't at that point. We typically have a low threshold for biopsy. We did end up having tissue in the end and negative for amyloid. So this is a rare case where we have multiple myeloma and heart failure, but there's no evidence of amyloid at all. So what causes cardiomyopathy? Reviewing all his risk factors and everything he had, he does admit to drinking daily for over 20 years, but he says 4 to 5 drinks a day. From what we know, what the literature tells us in terms of alcoholic cardiomyopathy, it generally occurs at higher doses, 8 to 9 drinks a day. The average is typically 8 to 20 drinks over an average of 15 years. So he's not quite at this, if you believe him and take him at face value, then he's not at the level that we typically see. Alcohol. How about looking at the rest of his chemotherapy? Bortezomib. This is the original trial for New England Journal that bortezomib or high-dose dexamethasone for relapsed multiple myeloma. And if you look at the bortezomib group, it's 15% incidence of cardiac disorders versus 13% dexamethasone. And really, 7 patients in the treatment group versus 8 patients in the next group had CHF during the study. But if you look at that, over 3/4 of them had previous anthracycline-based therapy. So bortezomib, looking at this, if you look at bortezomib-induced heart failure, this is a case series of less than 10 patients. Half of them had concomitant anthracycline use, and all of them improved the heart failure after cessation of bortezomib. So I think it's a possibility, certainly, but it's not a very high likelihood.
Yeah, I think that there could be a guilt by association because he has severe heart failure, severe LV dysfunction, and he's gotten anthracyclines before, and he's gotten bortezomib before. Those are all, and of course, he does have an alcohol history, although it's maybe not to the degree that you would expect. So yes, I would have to acknowledge that all of those are possibilities, but I would also say that we have numerous cases of patients that have a progression of their myeloma. We do an MRI. We don't see any significant findings, and we biopsy, and there's no doubt about it, amyloid in the myocardium. And I think that it's possible that he doesn't have that, but you know, the biopsy would provide, you know, potential information for some of these other conditions. So, you know, and I don't think a fat pad biopsy has ever helped me in the pursuit of amyloid in the past, although I recognize that people do them, but I don't think that it's been very useful. So we, you can hear my bias toward a cardiac biopsy, but I would definitely do it. But the you know, one thing that Joe said about, you know, it's not going to change your treatment, I don't know if that's entirely true, because there are a couple of newer drugs that are developed for specifically cardiac amyloid, that in the case of AL cardiac amyloid, and so he would potentially be a candidate for example, the NED-001 study with Prothena. He would fit that, except for the fact that he's on dobutamine.
Yeah, I mean, I think that he has, at an early stage, that we tend to be pretty aggressive because you don't want to miss the window of opportunity, but he may be beyond even any investigational drug at this point. That's why I was a little, I would have staged and got a fat pad biopsy just to see if you could get a quick diagnosis.
It's Brian Jensen. Can I ask a question? Maybe play devil's advocate a little bit. You know, recognizing that pretest probability that this is cardiac amyloid is high, you know, his hemodynamics don't look restrictive either by echo or by invasive hemodynamics. His BNP is not elevated disproportionate to a systolic dysfunction. So you know, do you see amyloid patients with relatively mild diastolic dysfunction when their EF is this low?
Yeah, that's a great. I mean, I certainly don't see patients that have that wash out that quickly with amyloid. And is not only the MRI was negative, and then but the point being that true that MRI is only about 90-95% sensitive, and the biopsy should be considered a high condition. But the echo certainly did not have any of the classic features of amyloidosis in terms of wall thickness and effusions. So, and he had a bone marrow that was didn't show any evidence of amyloidosis. But I think you know, for us, we have a very low threshold of biopsy for amyloidosis, and you can make the argument that we should have here, but we didn't, and we didn't have a lot of features that we would typically make us highly suspicious of having amyloid, other than the fact that he had multiple myeloma and heart failure, which perhaps is enough.
No, I mean, I think all those points are good, actually. I mean, I agree with what Brian said about the hemodynamic pattern. The only other comment is that was on dobutamine, so I don't know if that had a big impact on his hemodynamics, you know. So, but no, I mean, this is a fascinating case, and we struggle with these issues on these kind of patients all the time. So everybody has an opinion, and the opinions are not always the same.
So looking at other things, lenalidomide and it's an immunomodulatory agent derived from lenalidomide, and trying to look at the evidence of causing any cardiac issues. And I found one case report of myocarditis on therapy, and then another showing elevated BNP with this treatment, but certainly not a lot of evidence to suggest that this was incorporated quite a bit without cardiac toxicity. And then, you know, one thing that I certainly don't see a lot of, so I wanted to review cyclophosphamide toxicity and look at all the potential causes of cardiomyopathy in this patient. And looking at the literature, there's the minimum dose for having cardiotoxicity is not known, but there's no reports of cyclophosphamide toxicity at less than 100 mg per kg. I'm aware of or that I've seen in the literature. In this review, it found heart failure induced by cyclophosphamide occurred in 1.5% of patients with high doses, and
Well, you know, the really interesting thing about all this is, you know, Cytoxan or cyclophosphamide somehow has gotten under the radar for a long time, because when you look at all the breast cancer trials and all the other lymphoma treatment trials, they gave anthracyclines, but it was always in combination with Cytoxan. And so, you know, we always implicate cardiac dysfunction from anthracyclines legitimately, but the truth is that almost all of those patients got Cytoxan too. So how much is that a covariate? And I think that the one situation in which Cytoxan is given by itself is in the case of induction therapy, and clearly it has a rate of cardiac dysfunction given by itself in preparation for a stem cell transplant. So I think that it's probably a bad actor, but it's not been thought of individually because it's always given in combination with anthracyclines. So I think that it probably has a bearing on the story, I would say.
Yeah, that's a great point. And looking at the clinical characteristics of patients that had cardiotoxicity, it really, if you look at the duration from the administration of the drug to the time, it's usually a pretty quick duration. And one thing regarding this case in particular is trying to go back 6 years and figure out the timing of the doses related to its heart failure is a challenge. But this shows that most of the cases were diagnosed within days, symptom onset within days. And looking at the multivariate analysis of predictors of toxicity, including the type of disease plus dose.
Yeah, give me 1 second.
And then just one more literature review showing cases, looking at different case reports, also that associated high dose onset within typically 2 to 3 weeks. And looking at predictors from this study, it's mostly the timing of onset and specific details.
I mean, that's generally just loading conditions, right?
And then looking at pathology, the classic pathology.
She's like over the neutropenic stuff now.
You can find a specific pattern that can be diagnosed with cyclophosphamide toxicity, like anthracycline, other radiologies. And typically you have a severe non-specific interstitial fibrosis, but the deep panel, you'll see spotty hemorrhage or interstitial. C, you can see wall thickness and obstruction of arteries or arterial. And D, you'll see endothelial.
So she's always had now. I haven't seen her in 2 years. Maybe 2014.
That's here. So there are findings on pathology that.
So I would probably be okay in.
For this patient, he was
hydrating
diabetes and heart failure therapy.
I'll be happy.
We did it twice.
When she comes back to
Several bouts of severe attack of
somebody
cardiac.
in oncology.
He ended up doing an LVAD in this gentleman. But the major question we had was how would the interplay of chemotherapy interplay with an LVAD? You know? Looking at at 1 year, only 30% of patients with an LVAD are free for
Yeah, we probably all need to do that, and she should definitely make an appointment.
Device malfunction, broken death. So certainly,
Thank you. Okay, bye.
that should include a patient with ongoing cancer and ongoing chemotherapy, and how that would interplay with an LVAD was a major consideration. But we ended up going through with an LVAD, and of course we did have the apex that was sent to pathology and didn't show any evidence of amyloid, just for those of you who are wondering. And he did well for over 3 years with 3 admissions that were related to relatively minor issues, syncope and a spontaneous bleed that was self-limited. And unfortunately, last year his SPEP began to rise, and so he did receive 6 doses of carfilzomib, and also a proteasome inhibitor, and with more concern for cardiotoxicity related to Velcade, but he is protected with an LVAD to some degree, so it was decided to go forward with that treatment. Then he was placed on maintenance Revlimid until last summer, and then he stopped taking it due to financial difficulties. And most recently, he was found to have over 20% circulating plasma cells. So he had a bone marrow biopsy and was diagnosed with plasma cell leukemia, and is currently being treated with multiple agents, as you see here. So really, I just wanted to conclude by saying that destination LVAD therapy may be an option for a select group of patients with advanced heart failure who have active malignancy that's in remission or partial response to chemotherapy. But certainly much remains to be learned about the interplay of chemotherapy, malignancy, and mechanical circulatory support.
So what was the title of your presentation?
The title was Advanced Heart Failure Adventures in Cardio-Oncology.
That's certainly appropriate, but you could call it the Iliad and the Odyssey. Because that second case, holy moly, man, that guy got a lot of treatment.
Yeah, certainly. Yeah, and it was a really difficult choice. Someone with active multiple myeloma, but he didn't have a lot of comorbidities. And I guess he's done well for 3 years until recently. So 3 years of life he almost certainly would not have had.
No, I mean that is, and I mean it's a testament to how carefully you guys approach the whole problem. That's what I would say. But you're right. I mean, you could have thrown in the towel at that first juncture. And but I'm sure he appreciated the 3 more years of life.
Yeah, absolutely. And it really helps having a hematologist who knows what we do and knows about these options and advocates for the patient, because he has hematologists that we work closely with for amyloidosis and other things. And she's the one that pushed the private cardiologist to get us involved to consider this. So it really speaks to having close relationships with colleagues in oncology.
No, super case. The other thing I would say, so, it's interesting, you had, at one point you had an apical core, and you had a chance to look and see if there was any amyloid, and of course there wasn't any amyloid in that setting. But the other piece is, this is something that we've been contemplating, and hopefully will actually get done. But hearing about this case, I would say, if you guys would be willing to share your data or share your information to look at the pathologic samples, from the apical core, and look at them with a new light, because right now, I don't know if this is what happens at your place, but certainly this happens at Vanderbilt, is, the patient goes in, they get their LVAD, they get their apical core, they send it to pathology, they look at it, and they say, yep, that's a cardiomyopathy, and then they file it away.
Yep.
They don't do any special stain, they don't do any grading system, they don't do anything other than, simple H&E stain and put it in a box. And I think that we might be able to learn a lot from ourselves by looking at those samples with a new light and having some sort of grading system. So I don't know if there was a special stain or stains that could be done on that apical core and say, okay, was this related to Cytoxan, or was this related to bortezomib, or was this related to some other tissue, some other insult? And, I don't think that we've looked at those pathologic samples very carefully in the last decade at least. And I think it's kind of a new era. You have this new time in people's lives where you're actually getting a pathologic sample from the heart in a situation where the patient's still alive.
Yeah, that's absolutely right. I mean, that's great points, and we should talk offline about how to insert ideas of what to do with these biopsies, because you're right. We do have a lot of non-specific findings when we send them for pathology, and it would be nice to have a more sophisticated approach to them and see if there's anything else we can learn.
So you got some interesting pictures on your screen.
I just threw up that we've been working with vital images with 3D printing now, and we have one of our workstations devoted to developing STLs of CT data for 3D printing. So with conversation about VADs, I thought I'd pop this up just to intrigue everybody about what we're doing with 3D printing now. We're actually working on 3D printing of plaques in coronary arteries and how we can better understand the hemodynamics. So I just thought I'd pop that up. Hey guys, I really appreciate the conference today. This was an extraordinary presentation that we have recorded and will be posting for those who could not attend. The attendance was pretty good today. We had a good group. However, we may have had a little glitch in sending out notifications to folks, and so we will actually be sending to all members and all people that have expressed an interest in attending for each meeting, so that we can broaden our attendance.
Yeah, thank you so much.
We also would like to have volunteers for new presentations, and I'm open to that as soon as anybody is available. Please get back in touch, or you can speak out today if you would like to volunteer for a month for a presentation. So do we have any volunteers that are online today that would like to take a month? I'm not sure which months are available because I don't have Janelle's current list, but would like to see if there's some expressed interest so that we can match it with the current list.
I think I'm doing it in August.
Oh, that's good. That's the summer months when everyone's on vacation. So I'm glad we were able to get you, and you weren't on vacation. So please email or volunteer, and we'll see where the list is right now and see where we need and what the availability is. But this was a superb presentation, and I want to congratulate Barry for doing an excellent job. Unbelievable.
Absolutely. Fantastic.
Yeah.
Thank you. Thank you.
For the comments.
Thank you so much.
Thank you guys so much. Appreciate it.
We have Daryl and Isaac and Maria, Sebastian, Sonia, Calvert Bush, Brian Jensen, of course. We've had a great group here today. Thank you so much for attending.
Thank you so much.
Thanks. Great conference.
Thank you, everybody. Pats right on the back of everybody. Pat yourself on the back here. It's great.
All right. Thanks a lot, Eric.
Okay. You're welcome. I've been hanging around the kindergarten too long.